Good morning and welcome to our monthly webcast. This is a special case today. We have accomplished our 24 cases. This is the second anniversary. I'm also terribly sorry for the delay which have occurred this morning. Nothing to do with any patient-related complication, just some transportation delays. With that, let me take you straight to the cardiac cath lab, and we also have a special guest today in Dr. Alexander Apiciad from the Danta Pacineses Hospital in Sao Paulo. Alexander, welcome to you, and Samin, good morning.
All right, well, good morning. Let everybody, the little delay. I know that we are done.
Delays, Samin, related to some transportation matters, nothing related with the procedure.
It's I would say the New York traffic. So the welcome to New York from that point of view, the Big Apple. But yes, clearly that we did have in our this is our 25th present case that we have one time delay because of the weather related was snowstorm back in January, and one case actually, as you mentioned, that case just went further, longer, no complication, was another half hour or so, or 30-40 minutes. But without, except that, all cases have been up to the mark in finished in 60-65 minutes. But this delay was a little unexpected, but related to. But we are all set. Patient is ready, and we'll have some time to discuss few things. And of course, I welcome Alexander to be part in this live symposium, and Dr. Keeney just getting.
She's just scrubbed in to save a life from a STEMI?
Another STEMI, yeah. We don't get too many STEMIs here, but we get about maybe 3 to 4 per month. There are not too many STEMIs in New York. We can say, well, maybe because they go to a physician for regular checkup.
Well, or they come and have an acute MI in Miami.
That's it. Very rare. Non-STEMIs, yes, but STEMI, actually, while the countrywide, the STEMI non-STEMI ratio is almost 4 to 1 or 3 to 4 to 1. In at Sinai, the patients who are originating from Sinai, the ratio of STEMI non-STEMI is almost 10 to 1. We rarely get STEMI. As I mentioned, maybe 3 to 4 per month, while another 30 to 40 are non-STEMI, which present to the ER at Mount Sinai. We do have a lot of other STEMIs, so they're about 15 to 18 per month, which we do. They are basically transferred from our affiliate or non-affiliate hospitals. Many of them are because of our relationship with various institutions.
Samin, as you review 2 years of doing the monthly webcast, what are some of the highlights you have noted?
To me, I think the best highlight is if we can get to our slide 1. And I'm really proud of it because knowing that this concept we started back in July of 2009. Totally unique. There are a lot of other systems available, but we made this happen. Basically, that the whole concept of case presentation, discussion, and performance of case. We started with 237. July 2000, the page views was 237, and you can see over last 24 months how we have gone to average now is over 5,000. Unbelievable. It's a global audience, and I'll show you in the next slide over 100 countries. But what really makes us proud that we are helping teaching other centers to just become Sinai. People say, well, why? And actually you'll see 1 or 2 of those comments, people that some people will be envious of sharing their secrets of success, but not us. We want everybody to have a same kind of results, the excellent results with the lowest complication, and do all the complex cases. Clearly, if you avoid complex, you may have less complication, but that's not the goal. Our goal is to avoid, to do the right in complex cases and still have the very low complication. So that we want to share our secrets, the techniques, and that actually has been the focus over last 2+ years to just technical aspect of it. Of course, along with that, lots and lots of people have thanked me in various meetings that they have the slides comes like the cake on the ice, so they can just download all the slides and which is for everyone's use. And clearly during my presentation, Many of the slides I kind of go through quickly, but the purpose there is so that once some people want to go a little more details, they can always can refer to those slides and use in their own practice.
So, I mean, how much do you think this increasing viewership is a result of our partnership with the heart.org?
I would say very impactable. If you can see with the heart.org, this is our 11th. So last 11, I would say we got a real jump. Although we are sporadically went up to about 3,000 in our early time, but in last 10, 11 months, actually consistently, I would say, if we take an average, since our heart.org, we have full, it's a 5,000 minimum. Actually, some of them we have crossed the 6,000 mark. So that actually, remember when you asked me what is my dream for this CCC Live, my dream was to get to 10,000 viewers per episode, so that we are not far off. And clearly with your help and of course the publicity of the program, and I would say the heart.org, they really did a tremendous job, put it right on the front page, on their home page, and started the countdown, particularly for the 48 hours, and timely e-blast has really helped us to get there. And in next few months, maybe before year end, my dream may come true of 10,000.
So, I mean, I think that is exactly right. You had just mentioned about some physicians quoting. I think there are 3 or 4 other relevant emails which I think help us understand what we are doing. The first one you had mentioned was actually, I have tracked it down. This is Dr. Olsey, Alan Osley. He said, thank you very much for educated cases and sharing your with us. Many people would be jealous to share their tips and tricks.
Yeah.
I think that is well said. I also remember a wonderful note from Mauritius by Dr. Patel, who felt that Dr. Kinney had the best hands in interventional cardiology in the world. Anu, welcome to you. I see you have sneaked in there after doing the STEMI.
Yes.
Samin, what do you think also? I think one of the directions which CCC Live Cases has taken is the emphasis on the appropriateness criteria.
Yeah, I would say that clearly we know that how litigious this our field has become, and or not necessarily litigious, more important is the regulated basically auditing which is happening, and this is not unexpected because of some you can always say that there could be some bad players, and but key remains is that there was no guidelines in the past. What we are doing is right or wrong. At least the appropriateness use criteria, we call it OC. It gave us little guideline, and this is where our ACC time, myself, Dr. Krumholz and Jean Turco, we talked about that at least for an interventionalist, average interventionalist, there is some guidelines now that what is appropriate, what is not appropriate. Doing a 90% lesion is from interventional point of view, it's okay. But the whole question now coming down to that by doing it, are you changing patient prognosis? And that's where the appropriateness comes in. And we actually, as you have seen, since the beginning of last year, every case, and of course during our symposium and so, and anytime we do a live relay, our one slide talks about that colored graph which we have it in one, and of course we'll show in this particular case also that the appropriateness has really to the center stage. And because of that, at least a lot of our colleagues have understood this point and using that in their day-to-day practice, so that we take a pride in it, and I would say that at least significant credit from the New York State point of view. I just have a visit by another center 2 days ago, trying to duplicate or trying to learn how we can use this in their day-to-day routine. And for the New York site, from New York State, we are the vanguard site for all this appropriateness criteria. In addition to, because the state actually still looking into it, the lesion stenosis. Appropriateness kind of have eliminated the lesion stenosis, but for many centers, and I would say for our audit point of view, the degree of stenosis is very important, because if you start working on a non-significant lesion, you're tough uphill battle if you need to justify why anything was done. Of course, it could be done, but will require a lot of justification.
I mean, this is such an important issue. I want Alexander's feedback on this also. Alexander, you have these issues in South America, including in Brazil?
Yes, of course. First of all, let me thank you, Dr. Sharma, and yourself for this kind invitation. I think that the contribution of this didactic program is huge. And of course, Dr. Sharma taught us so much about new techniques in several complex situations that I think that this is well deserved. And I would like to congratulate you for this initiative and 2 years of this very successful program. Yes, SOLACI, the South American Society for Interventional Cardiology, helped a lot to put together this document with the SKY as well for the guidelines on how to do live transmission. And I think this is becoming seminal. I think it's extremely important to follow these guidelines, exactly what you see today. Somebody perhaps more doing more the talk, and then somebody really concentrating on the case. So I think that we should harmonize that in a way that everybody would follow this kind of recommendation.
Wonderful comments, Alexander. Pleasure having you join us. Samin, to me, your best accomplishment as I sit here has been to watch you do these in an unbiased, scientific manner, 24 highly complex cases, left mains, bifurcations, trifurcations, assist devices, complex rota stents, and to have no complication in 24 cases. To me, that is the hallmark, and if we can continue to teach people how to tackle these difficult cases, I think we would have achieved our mission. With this also, I have another very interesting email from a physician, Dr. Upadhyay. You know, he's the viewers teach you a lot if you can be humble and listen to them. And he actually taught us and our cameraman, and the cameraman used to have this tendency to focus on Samin and Anu, and Dr. Upadhyaya wrote that, look, we know you are good-looking doctors. It would be a better idea if the cameraman can focus on your hands and show the technique. So please keep sending us all the feedback, good, bad, and negative. I'm always there to learn from you. Samin,
and that is why, as you saw, that we actually, with our audiovisual team and Guy Puglisian, so we are trying to make it that every, while the case is being done, that there has to be a picture in a picture, and concentrating on the hands movement and so that that what has said by Dr. Upadhyay is really, you know, practical. That is what should be done for basically to achieve what our goals are of this live webcast.
Samin, we have a very interesting case today. You want to start telling us about that?
Exactly.
I know Anu is
this is about time now,
well.
because Dr. Anu is now ready to get some pictures, and I'll go through the case quickly first. Our 11th case with the hard dot and total 25th case. Is a patient presented, actually, it's a little different issue with this time we'll be talking, and that is as we have announced in the case presentation already, the somebody where the issue comes down to that because of their issues with the dual antiplatelet therapy, what is the right approach, what kind of stent you should use or so. And this patient will focus on that important aspect. Now, this is a patient presented in May with the crescendo chest pain and shortness of breath. No stress test was done. Because of typical story in 78-year-old male, they went ahead and did a cardiac cath. Patient underwent cardiac catheterization, and which revealed basically 2-vessel disease. And total syntax score was 16, with a disease in the diagonal and multiple lesion in the RCA. And the time the diagonal felt to be very significant, the patient had a cutting balloon PTC and DES with a Zions of 2.7518. And patient did fine, went home next day, but about a few weeks later developed GI bleed. At that time, the plan was to do the right coronary artery later, but then patient developed a massive GI bleed. Hemoglobin went down to from the 12 usual to about 6-7, required blood transfusion, and patient had endoscopy which revealed active duodenal ulcer, and patient was placed on high dose proton pump inhibitor. And they stopped the aspirin, and clearly this question always comes, that patient developed bleed on a dual antiplatelet therapy, and particularly recent DES, what to do in those cases. And usually we say, well, if you can need to take one of them, to take the aspirin off and continue clopidogrel. And this is what happened in this particular case. Aspirin was withheld and patient has been on clopidogrel since then. Now, history, as you see here, patient also had peripheral arterial disease, has some PTCA, and on good medical therapy. Aspirin has been on hold for last few weeks, and rest of the medical therapy shown there. Now, very important is, which is what we are going to show and ready to take a picture, that this patient has, besides the significant diagonal which already intervened, patient has multiple lesions in the right coronary artery, and many of them are calcific. And this is basically the issue comes that what to do with for this kind of particular case, require intervention now, although has been on single antiplatelet therapy and has done fine. What should be our right approach when you deal particularly the complex lesions? Simple answer, just say, well, use a bare metal stent. To me seems okay, but it's not a real good answer. Reason is that any of these cases, bare metal stent will have a very high restenosis. And once you have the high restenosis, so that what purpose we have achieved in those particular cases, so that always will be the issue. So that our goal today is the right coronary artery intervention, which Anu is just going to show. And should we use a bare metal stent or should we use some other stent? And particularly the whole issue about these two with the Medtronic Endeavor versus Integrity. The bare metal stent Integrity very flexible, and yes, but BMS has their BMS results. As you know, in the basket proof trial showed, even in the large vessel of 3.5 millimeter, that DES did better compared to bare metal stent. And of course, the Endeavor has been highly used in the short duration of antiplatelet therapy. Endeavor comes another handy in this particular kind of situation. Now, as you mentioned, the appropriateness criteria, which we take a big pride in it, show this is a color graph, and this patient actually will fit because it was class 2 to 3 angina and no stress test done, but on maximum medical therapy, which is double medical therapy, and still have 1 to 2 vessel disease, so fit into appropriateness of that grid. So with that note, I'll just now Anu has taken the picture and she'll take us through with this case. Anu?
Anu, good morning. Nice getting you back there. I know how stressful it would have been for you to shuttle between two cases and the delays, but tell us what you've seen in the angiogram.
So if you can see the angiogram, you see the left main and circ was non-obstructive, and his diag stent, which was Zions V stent, looks okay. He did have moderate disease in the mid to distal LAD, which I think is a lot of it could be a bridge also. But and this is another point that
GI bleed, no question is GI bleed is stopping some therapy, so it still looks quite good, the diagonal. So they at least reassuring that even with a single antiplatelet therapy, this patient did okay.
Severe calcification of the right even without cannulating the vessel.
Yes. See, the other point that we want to make also is this is the guide catheter which we have used to go into the LV, and just always before you do any complex case, just check EDPs. EDP is 15. I think if you are advancing the wire ahead of the guide, you can go ahead and the same. We took the picture, LV quick picture with the guide catheter itself. And this is exactly the right coronary artery. If you see from the mid, you have an angulated, eccentric, calcified vessel, and important is distal, distal and AV continuation and RPL, calcified and significant disease all the way down.
7 French guide?
This actually is a 6 French guide that we have.
Yeah, reason is that remember 6 French, somehow I feel that gives you better support, and then you can get up to 1.75 bar. Right. And I don't expect to use a bigger bar than that. So, but clearly for the distal lesion, it will require a lot of negotiation, and the bar has to be advanced further to get to the distal segment. So the our goal is, because of calcium, that probably do a rotational atherectomy, and while they are trying to get it, we'll go through a...
considering the distal lesion and the tortuosity, you think you may have needed better guiding catheter support like an Amplatz or something there?
That's a very good point, yeah, and I will ask Bandu to answer this, and maybe you will have actually the point, that's a very good point. But the question always comes is that if any other guides are a little more aggressive, there is a mild lesion at that ostium, not ostium, at that angle. So that if that creates a little trouble, so if you can do it without, fine, but you're right. not many people will start with the MPLATS 0.75. I probably would have gone with the AL 0.75, but this was Anu's decision, and she will highlight that as the new addition which we are doing in our case.
Doing 25 cases, I have become smart enough not to second guess Anu.
Okay. Now, while they are trying to wire it, and so we'll go through our always we try to have two issues during our presentation, and knowing that we are already a little late, so I'll try to go through a little quick. And as I said, that all these slides are always available so that for further discussion. The goal basically is that in this particular case, that what should be the minimum duration of the DAPT post DES, and I'll give the data on some of the randomized trials and which are done or which are coming. And secondly, if you need to stop it, what is the best way or what is the minimum duration of the DAPT discontinuation in these particular cases. So that basically start with the first one. We know the stent thrombosis is a big issue, particularly with the drug-eluting stent. Incomplete endothelialization, antiplatelet therapy duration are a very important factor besides the patient and procedural and the stent technique, that these really determine, in my opinion, all those factors are that whatever you need to do. But key is that what differentiate the drug-eluting stent from others is the delayed endothelialization and antiplatelet therapy duration, which we know that overall from the we learned that bare metal stent can endothelize within few weeks. Remember the original trials of the STARS and showed ISAR that there was no stent thrombosis after 2 weeks. So if there is an issue and we know that patient needs urgent surgery and minimum time duration, you can put a bare metal stent, 2 weeks of antiplatelet therapy, and let patient go. There are some data in the past that there were events up to 4 to 6 weeks. Then there were data from North Carolina, then were from Mayo Clinic, that sometimes it require about 4 to 6 weeks to really get the event down after surgery. But otherwise surgery, if surgery is not a part of it, we know stent thrombosis with a bare metal stent is a very rare event. If we are done, all procedural issues have been taken care, good stent deployment, it occurs in less than after 2 weeks is extremely rare. And that actually led to the various guidelines over last few, I would say in last decade, including when the DES came, with the taxes being 6 months and Cypher being 3 months. So those became part of our guidelines, that you need to give dual antiplatelet therapy 6 months with the taxes and paclitaxel, and with the Cypher being 3 months. And then we also learned at the same time that this issue of the delayed endothelization, which can be seen in by endoscopy and as well as by in the histopathology, that there is a delayed issue, delayed endothelization, so that it's not bare metal. There is a difference in bare metal versus drug-eluting stent as far as endothelization is concerned. So that as soon as you stop the antiplatelet therapy, you could be risking patient for stent thrombosis and so. And this we actually learned. I would say the first one of this was the basket late trial, and I actually put it ACC, although later on then it was published in JACC. And so the key was that this is the first time, even before the firestorm of the European Society in 2006, which happened in August, September, that March we had a signal that what they did in basket late, basically that after 6 months, patient with the DES and BMS, they stopped the clopidogrel and followed them for 18 months. And look at that, DES, which is in the red bar, versus BMS, every event was higher with the DES than bare metal. So basically the message was very clear that DES without long-term clopidogrel is bad compared to bare metal stent. And of course everybody knows about the that issue, which really took the world level, not national scene, at international level, and then came with the 0.6% stent thrombosis per year. And this actually was confirmed by our earlier trials of the both Cypher as well as Texas, that after 1 year there was a 0.6% stent thrombosis in both those trials. And another data came that if you put a DES and you stop the thienopyridine after 30 days from the premier registry, your mortality at 1 year was 7.5 versus you continued, then it became 0.7. So very important. And then the same data that premature antiplatelet discontinuation have an odd ratio of almost 80%, to have a stent thrombosis. So very important that long duration of antiplatelet therapy became primary focus. And of course then we have the data that if you need to continue 6 months or 12 months, and basically these are the from the Duke, the data published in JAMA, that if you continue 12 months, that really brings down your stent thrombosis with the DES and clopidogrel, as you can see, became 000 with the death and MI. Best combination. So the DES with a long-term antiplatelet therapy of minimum 1 year was preferred, and that led to the FDA guidelines that you continue for 1 year. That was the minimum requirement, and of course we know that if you had to stop it, then you do a bare metal stent is the preferred. And now the question has been that 1 year, yes, you can continue, but there is what is the risk? Risk of the bleeding. What can you do? Can you decrease the duration? And the first randomized of its kind is the excellent trial which is presented in ACC, and basically comparing 6 months versus 12 months. And you can see here, while overall it may be look okay, but if you go to the nitty-gritty, stent thrombosis was 6 months was 0.8 and 12 months was 0.4. And if you are diabetic patient, target vessel failure was almost 3 times higher in a 6-month approach. So that in my opinion, so far still we don't have a final answer, and I would still say that 12 months seems to be the preferred approach, not the 6 months if you take all patients together. But at the same time, there are a lot of trials ongoing at present which I have shown here, and the most important being the DAPT. That is, do you give it for 12 months or you continue for 30 months, which is the 20,000 patient trial headed by HCRI with Laura Mori, the PI, and we really will have an answer of this issue in coming few years. But clearly, that should be 12 months versus 30 months where all DES will be evaluated. And actually, Medtronic as a leader in this field, they actually have their own multiple trials. The physician initiated as well as the randomized trial, and we'll have this answer that what is the shortest duration. And these are the definition of the ARC, definition. People ask all the time, definite, probable, and possible. So now we go to the second point, that is the discontinuation. That patient is not uncommon. You have put a DES in all faith. You did not know patient was going to go for surgery, but patient developed cholecystitis or broke the hip 2 months later. What you do? Develop GI bleed. And those are the very common cause, most common cause of discontinuation is the unplanned surgery and the bleeding. And therefore, those are a major issue. Now, if we know beforehand, we don't do the DES on those patients. And that actually, this data shows that once you have the think about the DES we know that patient is not going for surgery, patient is not having a bleeding issue, so that those are the one we want to put a DES. And the issue further becomes that once you do surgery is the prothrombotic. And of course, when you have bleeding, like this particular case, you stop antiplatelet therapy. So all those really cause high level of the risk in terms of stent thrombosis. And therefore, discontinuation or DAPT interruption is very important. We also learned that if you take aspirin alone, maybe 4% stent thrombosis. If you are none, then 16%, but if you take both, then it's a less than 1%. So the goal always have been that we try to continue dual antiplatelet therapy, and there are some data actually have looked into, can you stop safely at 3 months, 6 months, or if patient needs it. This is the original data from Stents using the Medtronic stent, and found that less than 3 months you still have an event rate of 8.9%, versus if you delayed it more than 3 months, which was usually 12 months, the event rate goes down to less than 1%. So 3 months is still not good. Second, now that then the Korea, they presented the date registry that only do clopidogrel for 3 months. In 17% of cases, they continue more than 3 months in this 823 patients. It was registry. But overall seems to be that stent thrombosis was less than 1%. But again, this is a registry, and not all types of cases were used in this registry, so that it still need to be answered, in my opinion, in randomized. There are many data from various of our trials of the Endeavor as well as the Sprit trial that 6 months kind of breaks down this ice. That after 6 months that you can stop discontinuation, probably event rate goes down lower. And this actually was really looked into the Science v USA. As we know, with the divided standard cohort versus all comers. Standard means that low risk, and basically found that if you overall, that after 90 days interruption, that at 6 months you can see that after stopping 6 months in not a small number of patients, overall patients were about 500 who require interruption, that there was 0 stent thrombosis after 6 months. At 3 months still there was 0.26. But if he is a low risk, then it's actually you could stop it even after 1 month. But overall, I would say the message still is that 6 months has to be religiously followed to decrease the stent thrombosis. And actually our data we presented also, and this paper is under review, that after 1 year, if you stop the DAPT, that what is the minimum time duration when the stent thrombosis occurs. And it turns out to be that no report, I yet to see a report, if you're given a dual antiplatelet therapy for 6 months and so, that less than that if you stop it only for 7 days, there is no stent thrombosis. It only occurs after 7 days, 10 days, 3 weeks, or 3 months. So the 7 days seems to be a very good period. You can say the safe period in case you need to stop the DAPT, but particularly if you are given it for minimum 6 months and so. And this actually the protocol which we adopt at Mount Sinai in these patients, basically again incorporate that how long patient has been on the antiplatelet therapy after the stent deployment, and basically is that if you are 6 months is kind of the period so that you can just stop it and do the surgery, and 2 days later restart the antiplatelet therapy. So that basically what I'll do it now is just basically conclude quickly that decision making for the DAPT interruption is very important and require a lot of communication across the various specialties, because one specialty may not just decide to stop it because of that is good for them, mostly surgeons and so, but no, it has to be the cardiologist, everyone has to be part of it. And more important, there is a lot of research is focusing on the limited duration of DAPT with a bioabsorbable DES with biodegradable polymer, polymer-free DES with rapid endothelialization, drug-coated balloon, and so on. With that note, actually Alexander has been involved in many of these trials, and so it's the right time come in terms of that where we are, and we know patient needs DES, and we know that patient will require some surgery, high risk lesion like this case with the multiple lesions in the RCA. We know you can put a BMS, but this patient will be back within 6 months with a 50% restenosis. So that what you think is in the horizon, will be dealing with these cases.
Wonderful. I think Dr. Sharma made a very strong point that we really don't have an optimal solution to avoid stent thrombosis in some of the situations after DS. So I think there is a lot of room for improvement in terms of DS technology. I think we all know that we started with first generation durable polymers, very thick polymer that could be more inflammatory to the vessel wall. I think it's evolving very fast, the field, in a way that now we have available, mainly outside US, hopefully very soon here, stents DS with bioabsorbable polymers, which has a very good rationale to stop PLAVIX early on, since the polymer and the drug is gone in the first 3 to 6 months. Now we are testing many prototypes outside US as well with non-polymeric DS. We thought in the beginning that late loss could be a little bit higher and that we would lose a little bit of efficacy, but we are proving now that with no polymer we still can keep the same efficacy and perhaps improving a little bit safety. And finally, we will be introducing fully bioabsorbable stents very soon. So just to summarize to the audience, those are the two prototypes and two stents, not really prototypes because it's been used widely outside US, that use bioabsorbable polymer. The first one is Biomatrix with a company called Biosensors, and that's a combination of a metallic stent with a drug called Biolimus A9 that releases with a bioabsorbable polymer. In the next 6 to 9 months, the polymer is gone. The other very interesting technology is the combination of endothelial progenital cells that can promote early endothelialization and perhaps being a more pro-healing approach with sirolimus to keep the same efficacy. Next. And now even more interesting is a few non-polymeric platforms. Medtronic is developing a very interesting hollow stent with a bunch of holes that can release zotorolimus or everolimus from these holes without any polymer. And then BioFreedom is another example, Translumina, the CID technology with reservoir, no polymer, releasing a limus drug. And finally, with hydroxyapatite, which is a ceramic coating that creates this 3D architecture that absorbs drug without any polymer, releasing in the next 30 days. Next. And finally, and perhaps more exciting, is now we are very advanced testing fully absorbed stent. There are at least 5 or 6 companies that develop fully bioabsorbable technology. I think the most advanced one is the BVS one by Abbott, that we see that it's a PLA structure that releases everolimus, and then at the end of 18 to 24 months, everything is totally resorbed by the body, and then we end up with a vessel totally with back to the vasomotion, as you see in this slide. This is a histology showing that as we test this device, as we have histology over 3-4 years, there is nothing, and the vessel can go back to the normal vasomotion, which is something very attractive. Next.
And now the trial is being done with the BVS?
Yes,
yeah.
we are doing major trials. We had cohort A and B with 3-4 year follow-up, and we started a 1,000 patient registry all over the world that will test this new technology in a more real-world situation, such as multivessel disease and 2 stents with overlap in the same vessel. So we are really struggling to come up with the best solution to minimize dual antiplatelet therapy, and I think that we'll have this answer very soon.
Very good. So that in the future, once we have it, we know that patient going for surgery probably will be put a BVS stent, right? I mean, that's, or at least polymer free.
Exactly. So
Those
that's going to be a very good solution, I guess.
Samin, thank you both for excellent presentation. Alexander, I'll keep bringing you in for some very relevant feedback into this case also. One of the innovations we've done at the monthly webcast is that I have requested Dr. Kinney, before she starts the case, to anticipate and tell us what are the technical challenges she would have. Anu, can you take us briefly through this case? What do you expect to be the issues?
So if you see the angiogram that's playing, if the lesion starts in the mid RCA, calcified, and more important is the vessel itself is angulated at that particular area, and then majority of the disease is in the distal RCA. Actually the PDA is very small, AV continuation, and all the way up to the RPL. So like they have already discussed, I think the first thing is what would have been the guide selection here. I think aggressive guides which are AL, starting right from either AR2 or AL 0.75, AL1 could be the guide. But what happens in this particular case is that you see proximal disease just where your sinoatrial node branch is coming off. So your guide tip will be sitting at that area, and every time that we are trying to work in the mid to distal RCA, it could cause trouble, especially guide induced dissection. So majority of these cases, what we try to do is, since we have a long sheath, which we have discussed many times in the past, using Lima guide, which gives probably moderate support, and further on with the wires, we should be able to do our procedure. The second would be how to take care of this calcific angulated lesion, which we know, I think we do have to do debulking with the rotational atherectomy, and be ready to do the lesion preparation, which means you need to have multiple balloons ready, that you will start with 2.5, since the lesion is long, 2.5, 20, 3.0, or maybe even a 3.5 non-compliant balloons that should be ready in this particular case. And the most challenging that I would think is how to get a stent delivered to the distal RCA. We need to have definitely double wire strategy. The wire should be the workhorse wire that you use, and then could be a polymer coated wire so that the stent may glide, or you need to have your Grand Slam or Mailman ready with you. And the last would be that have the guide liner, because in many situations we could be that we may need the guide liner to get the stent delivered to the distal. So these are the I think 3 points, and this is how that we have all our devices ready. We are planning to do rotational atherectomy. Though the vessel itself looks almost a 3.5 in the mid RCA, since since the lesion is angulated, we have to downsize the burr, and we have gone with the 1.5 at that particular area, and the goal is to do rotational atherectomy even in the distal RCA, and the challenge would be to get the burr to the distal RCA.
And from the wire point of view, you would not suggest to go with the rota wire directly?
Yes, I mean how to wire is that have your transit catheter either a 1.5 balloon or any kind of a transfer catheter that you have. Go with your workhorse wire and then change it to rotawire.
Anu, as you proceed with preparing the rotablator, Alexander, is this how you would approach the case in Sao Paulo?
Well, I have to say that many people say that rotablator is not very active in multiple centers, but in a case like that, I totally agree with Dr. Keeney that it's extremely helpful. I don't see us going so easily with any stent, deploying any stent without atherectomy in this particular case with a lot of calcium and tortuosity.
Excellent. Just to make your statement very pertinent, Samin, here is an email sent to me by Dr. Mark Shima. An excellent case and a great review for rota stent cases, especially for those of us who have fallen away from using rotational ablation in the past few years.
Right now, other question I think is still, to me, although I made a pitch that if you have single antiplatelet therapy, that should this patient, the pacemaker should be on. No, you go to 70. Yeah. Pacemaker, remember it's not uncommon for these pacemakers many times that called asystole, the pacemaker advance.
Advanced.
The 70, give atropine also 0.6. Yeah, therefore, I know a lot of people say, well, why to put a pacemaker? Yes, if there is, we know that pacemaker may cause complication. It's a different story, but just put it so that it's, and leave it at 70. I think what happened is pacemaker moved a little bit, we have positioned it, everything is good, and go ahead. I think the big issue in this particular case would be that despite all the limitation, that although we have said that maybe we should do a bare metal stent, that should we do a bare metal stent, knowing that it's a very complex lesion and will have a very high restenosis.
See, another important point I think we need to be demonstrating in this case is that the 90 centimeter of the burr length has been used by starting burring right from the mid RCA going all the way to the distal RCA. So this would be an important point to say. Now, if you see here, so I reach the, so I would want to go distal, and how do I do that? Come all the way back. And what you do is your knob, make sure your knob is tight, and then I will go on dyna, and here you have to do the brake release, and on dyna I'll be advancing, and now we will face that the guide will start kicking out.
It will not go. Just try, we'll do the second technique.
Okay, let's try now.
Yeah.
Brake release. This is usually what we always face, but at least still I think we probably got it a couple of centimeters ahead.
Yeah, that's right. See?
Now we got the, if you can see, now I'm able to go all the way distal before the start of the RPL.
Anu, what's your burst speed there?
About 150.
Alexander,
that has been our, all of them, yeah.
Alexander, how often are you using bare metal stents in Brazil?
Well, that's a very interesting question. We have two different situations. When we go to public hospitals in Brazil, it's average 80% bare metal stent. Unbelievable.
Wow.
Because we don't have reimbursement.
Is that because of cost? Because with the Brazilian real, you could buy anything in the world these days?
No, totally because of cost. The government didn't figure out how to reimburse for DS yet. On the other hand, when I go to my private practice, it's 95% DS.
Yeah.
So we have two different approaches in the same country, which is very interesting.
Samin, a quick question from one of the viewers. What is the percentage of BMS used at Mount Sinai?
Yeah, it's about 12%. And the majority of them are scheduled surgery, and some percentage, those who are getting the acute MI setting with a large thrombus burden, with many of them are still concerned, although there have been a lot of trials which have been done, Passion, Typhoon, and now the Horizons, showing that there is no increased stent thrombosis, but many times you don't know these cases, whether they will be taking the medicines or not, so that they would like to put a bare metal stent. So that overall is about 88% DES, and those 12% are, those patients are going for scheduled surgery, and some cases of, the, you know, as I said, patient with myocardial infarction. The large vessel no longer is the criteria in our cath lab. that those patients should be done with the DES, with the BMS. And particularly now, that data support, although we learned even in the earlier trials of the Texas 4 and so, that once you use a 4 millimeter, it was 0% restenosis compared to 4% if you use a bare metal 4 millimeter. So that basically, and now with the basket proof trial showing that yes, even in the large vessel of 3.5 millimeter and above, that showing that the DES better, so that clearly the vessel size is no longer a criteria. Now some cases, I would say the vein graft, I think the jury is still not out there for the vein graft, per knowing that the initial bad press from the risk with the cipher, but subsequently some studies both with the paclitaxel and everolimus have shown not that bad, but still there is some signal of a slightly higher stent thrombosis and so in the vein graft. So that only one issue, in my opinion, remains where the DES has not been clearly shown to be a beneficial is the situation of the vein graft.
I think those are very important points. Anu, you think you were able to go as distally as you wanted with the rotablator?
Yes, I think we've been able to do the rotational atherectomy up to where we wanted, and now something that we have never done in any of our previous cases is how do we, usually what we have shown that when you are now going with your second wire, you go side by side. But in this situation, we are predicting that since we have to do a stent delivery almost to the distal RCA, that we would take a Grand Slam wire, and what we have on the rota wire, we would go use your transit catheter or the wire balloon to go all the way down and exchange the rota wire to the 300 Grand Slam all main wire.
Yeah. Although you can try side by side. But to me, why? You already have your stuff. That's how you put originally. Just go through it so that you are exactly in the same lumen where the rota bar has been done. You can see, and I'll go through frame by frame, that we have created a little gutter at a 9 o'clock position, but that's expected. That is what the rota is supposed to do, that make it a little channel. And basically that's a part, again, many of things which people say, well, that's the rotablation caused it. I said, no. That is what rotablation is supposed to do. Same thing like when we used to say PTCS caused dissection. That's good. That basically means that now we have cracked the lesion. The same issue comes in that I would expect the rota bar to cause this little gutter effect, but patient is fine. There's no diastasis. We are not talking about dissection. It basically that it has created a wire bias approach. So you want to remain in the lumen of the rotational atherectomy.
So more aggressive wire support strategy here.
Yes.
Samin, the next question to the bare metal issue comes is which bare metal stent?
The balloon?
Yeah.
2520.
Yeah. That's a good point. I mean, I think we actually have experience, quite a big experience on both vision as well as integrity. But integrity actually, since it arrived, it is very flexible. We found a little extra edge over vision, so that we do use vision also, but majority of the bare metal stent at Mount Sinai is integrity because very deliverable, and
that's also been made on their AVE platform, which used to be a remarkable stent.
Yes.
Alexander, what are you using in Brazil for bare metal stents?
Well, I think vision is perhaps one of the most popular. We do have Liberté also that we use very often. Integrity is coming. So those are perhaps the three most popular stents. But I have a question to Dr. Sharma. I think that in a high-risk patient like that with previous bleeding, and if we feel that we're going to use long stents, probably the rate of restenosis is going to be higher. Would he consider, and Kini, of course, the use of Endeavor, for instance, which is perhaps a less thrombotic stent? This is an option here?
Well, I would say that more and more, particularly that how the diagonal looked so good with a single antiplatelet therapy, I'm inclined, and of course it's a new patient ask what to do. I would say that I think we give this patient the best, although our plan originally was use integrity, but we should change the plan and use the Endeavor. I would say that give this patient definitely benefit of the drug-eluting stent. right? Well,
We are running now a very big trial in Brazil called Optimize.
yes.
More than 3,000 patients being randomized 3 versus 12 months. Of course, we exclude extremely high-risk acute MI patient because of you can tell better than I that the benefit of dual antiplatelet for acute MI 1 year there is evidence for that. But for a case that is more stable and high risk for bleeding, I think might be an interesting option. So we have to prove that scientifically with a robust trial. And Dr. Sharma highlighted that in his presentation. We need this big randomized trial to be able to prove that we can decrease the use of dual antiplatelet therapy. And we keep ignoring the risks of bleeding, which kills people as well, as you know.
Alexander, with the Endeavor, what is the duration of dual antiplatelet therapy you're using?
Well, in this trial, we're gonna randomize 3 versus 12 months. So,
But what are you using at the moment?
oh, at the moment, we use in most of the cases with relatively high risk of bleeding. We already adopted the 3 months, but average is 6 to 12 months as any other DS.
Alexander, tell me also what's your present level of enthusiasm for OCT?
Oh, extremely high. I think as a research tool, is extremely helpful. And with essentially all the first-in-man studies that we are conducting with new stents, new drug-eluting stents, I think it's a great surrogate for safety. We need to prove that, of course, in large scale and try to correlate the OCT findings with clinical findings. But right now, to see 95% of the struts covered by tissue with OCT, it gives us a level of comfort that can be translated into clinical impact.
How much is the penetration of FFR in your cases now?
Well, we are trying to adopt FFR since we are very much IVUS people there at Dante Pazanesi. I think that it was a little bit slower for us to adopt FFR in multivessel disease, as the FAME study claims. But I think that for intermediate lesions, when we feel that we have a culprit lesion that will be treated already well defined, I think it's very helpful.
Samin, what are you doing there now?
Yeah. Now, actually, what I'm using is the guide liner
Okay.
to give extra support in this tough case. Okay, you go in with the balloon. Yeah. So we still need to open the very distal lesion, which has not been opened. This is the guide liner. So he stays it in the side. And which balloon this one is now? 2.5?
Yeah, 2.5 apex.
Yeah, 2.5 to 20 apex compliant. So we need to still go to the distal segment, which we will not able to cross with the non-compliant balloon. Now that may be the last 2 millimeter, which were not had a rotational atherectomy. So that may be the factor. But we need to dilate that.
We were able to do
We did, okay. That area, yeah. Good? Okay.
Samin, for patients having GI bleed, what is your threshold these days for transfusing them?
Yeah, I would say that the same, that not just a regular anemia, but we see the sudden drop of hemoglobin that we try to clearly, that remember all the trials of blood transfusion are that if you found anemia, but this is not the case, that if somebody bled GI, that's better to you keep around 10. Now, do we prospectively, in the past we used to just not do even PCI on anybody whose hemoglobin was in single digits, but there is no longer that applies now. Now basically, as you can see here now, the guideliner has gone to the mid RCA. We have done the PTC of the distal and now we're ready for the stent.
Yeah.
Okay, you dial it here. But yeah, that means that the lot has been gone because there are some data that has shown actually from both Acuity and Horizons.
27530.
Yeah, that has shown that for the same level of anemia and drop in hemoglobin, if you give a transfusion, your event rate goes even further. Whether it causes a pro-inflammatory or it's a nitrous oxide issue, and so release cytokines and so various factors increase Rulux formation. So the various factors may contribute to it, but that actually has been the factor that our threshold and is basically excitement, which used to be using the transfusing, has gone down significantly now. Yeah, we can use 3030.
Anu, bivalirudin for this case?
Yes, yes, yeah.
Yeah.
Alexander, have you been using bivalirudin in Brazil?
Just got approved in Brazil. It's getting approved in Brazil. I think towards the end of this year.
So you're not necessarily ahead of the United States with everything.
Not for this. Not for this. You're totally right. You caught me.
Well, look,
MO MACE is coming towards December. I think there will be a lot of enthusiasm and great adoption, but we have to see. In outside U.S., the cost is always. I think it's coming to the U.S. as well. We are discussing more cost here, but this is an issue there. But I think that will be a great number of people that will adopt very soon.
Yeah.
Samin, bare metal stents, when you're deploying them, do you post-expand like your strategy with the Zions? Or,
yeah, we learned that bare metal, you need a more expansion, and therefore you want to get to the lumen, that typically 7 millimeter square or 6.5 has been shown in many of the trials, so that try to go, the 18-20 atmosphere is good enough. I go with the bare metal, it's the same. Now, if you cannot go that level, then only you need to post-dilate with a different, now as you can see, despite despite guideliner and here, that this is a 3.0 30 millimeter endeavor. We have, I felt when I think everybody felt the same. It's a complex case, even if the limited antiplatelet therapy or even single, that just go with the, we continue clopidogrel, and we definitely will test this patient, but I don't know will be of what value, because we are not going to change. You cannot give prasugrel these patients with a GI bleed, and this is the classical demonstration of use of the guideliner here. To get our stent delivery, 3.030, try to get distally. Of course, you could use the shorter ones, but the goal here is that cover by one stent distally and one stent in the middle. But we decided, though we went ahead, we were a little different than what we announced originally, that we'll use a bare metal, but taken all things together, I think using the DES is right thing to do.
Deep breath.
Alexander, how aggressively have you moved to prasugrel in Brazil?
That's now a good question, because we have prasugrel approved. I think we are conducting a few trials internally, but essentially what we do is when we have an acute case, an acute MI, for instance, or unstable angina, that we need to have antiaggregation very soon. We generally, now it's our protocol to give prasugrel, and then we can decide, due also to cost issues, if we move back to clopidogrel or not. It's in the very beginning, but I think that there will be a consensus soon when we conduct larger trials internally.
How far do you think you are from ticagrelor?
Beginning of next year, January, February next year. AstraZeneca already started the training, so we should have available very soon. And that's going to be very competitive.
Samin, you think you got it distally enough?
No,
or
I think we may need another short one distally.
Yeah.
And it's not uncommon. Not uncommon that in a long lesion that you cannot get a distal one but deploy proximally, because then you'll make a lumen for you to able to advance the stent distally. Now, other technique which we have said, that you can jail the wire and make it a rail. You put a double buddy wire and then you can make it a rail. But here, actually, you already have the guideliner to help that. So always do 2 quick inflation. I think we're just reaching there our time.
Okay, we have to bring the stent quick.
So for the second stent, you would also use a shorter endeavor?
Yeah, this is
2.524. This was a 3.030. I think we'll go with a 2.524 just to cover that.
24 or 20 even. Okay, we'll see.
20.
So, Dr. Mehta, in your practice, the use of prasugrel, since you're dealing a lot with acute MI patients?
100% switch over to prasugrel, except for those 3 indications, previous TIA, stroke, elderly patient and small weight. Even those sometimes I cheat upon, but just about I think it's the most favorable drug for STEMI.
So we agree on that, yeah.
Yeah, the critical point I think is that I think one of the challenges we have with the STEMI interventions in the United States is that I don't think we are initiating the treatment fast enough, and I think it should be done in the ambulance.
So you would recommend the aspirin and prasugrel at the ambulance when you first identify before you remove the patient?
Yeah, with the definite diagnosis of STEMI, with there is going to be a subset of some indeterminate patients. For them, you hold it, but the logistics and the medico-legal situation in the United States is not going to make that easy. But internationally, I am seeing that the two major endeavors which are going on to reduce the door to balloon times as well as to improve the results are early antiplatelets in the ambulance. There are some countries where you are even able to give them a bolus of heparin, and then the more critical issues to bypass the emergency room for patients who are more stable and when the cath lab has been alerted and they are ready.
Okay, now Anu, tell us what did we see here? What did we inject?
Okay, so if you go back, I think how did we get the stent further down? So if you see here, this is exactly with my, just before I could get the balloon distally, the guide liner, I was not able to get the guide liner into the vessel. In that situation, what you do is you take your balloon, pre-dilatation balloon, and dilate. When you are dilating it, then on the balloon and the wire, you will be able to advance your guide liner like you see here. So I was able to get my guide liner there, and now we were able to get the stent, and stent was there almost from the distal at the acute angle, and at that level we were able to get the guide liner further down. We deployed the stent in the distal area, but we know the AV continuation RPL angle has not been covered by the stent, so that is where we are with the new stent now.
Right now, just dilating
Just
the balloon
another
first.
word.
Once
Balloon.
more.
Prepare
Yeah.
that particular angle with the balloon.
All right, that went quite easily.
Yeah.
The balloon does, but now we are ready for the stent again.
So this is the
That will be
extra step. You have to be, you may think, oh, let me just quickly do the stent and come out, but you know once the stent is there, you may not be able to, so just
Go within the
pre-dilate
stent now.
again.
Keep it within the stent also. You just post dilate.
Yeah, here.
Yeah.
One extra step, but just to make sure that you have one chance now to get your second stent down, distal to this deployed stent.
Alexander, happy
Yeah.
with the way
Good. Go.
Solasi has developed?
Say it again.
You are happy with the way Solasi has developed over the years?
Okay, down.
Yeah, it's grown. It's a relatively young society, 10, 12 years that we exist. But now it became not only an international meeting, but also we are coming up with our own guidelines. And I think that the training of international sites all over Latin America to be able to do high-level research, that's something that really pleases me. And that's something that we can really collaborate with US and many other countries.
Wonderful.
This is 3024.
Yes.
This will be the real test. The real test of the plaque modification.
Well, I think it's going to be really a test also of the guide liner and how Anu has placed it. And which is exactly, I go back to the first slide of the technical challenges which she had mentioned, and these were all anticipated, and I'm glad that Anu spent enough time reviewing those.
That's why we waited for this patient. We had another simple case, but we didn't want to go with that. See
Now
that?
just
right.
look at that now.
Wonderful.
But a very important point that I want to make is that the initial same thing, the guide liner, we are not able to get in. So your thing is go with the pre-dilatation balloon, get your guide liner further down the vessel, and keep advancing slowly as much as you can. I think we are at the right spot. Go ahead. Now get us another 30.
3.530 approximately. Mid.
3.5, now
Mid.
go through this with the guide liner.
Yeah, the guide liner you take it out.
So this
May
is
not
a
go.
27524 or a
3.5?
25?
30.
Okay.
30.
Three or
Why
20.
don't we post dilate? If we go 3.5, no? Or should we try 3.5? May not go with the guide liner.
No, we'll take the guide liner does not take 3.5?
No. 6 French will not take it.
Okay, this is the 6 French guide liner. Going through the 6 French guide may not take
No, no, but
3.5, but
it's
we'll
in a
see.
good position.
But otherwise, yeah. Otherwise, we'll go
3.5.
directly.
No, may not go directly. That angle.
Yeah.
Down.
Always overlapping area, dilate again, so that nice apposition. Cut down the pacemaker rate to 50 now. Now, what is the limit? With the guide liner, you can put up to 3.
No, if it's 7 French, for 6 French
Yeah.
is 3. 7 French, though they say, company does say that we will try, that 3.5 will
I
go
can tell
through.
you, the companies say all those funny things. I put a 2.5 302 stents through our mark guide. They say, wow. I say, yeah. Whereas many times the smaller 2.5 302 stents will go through your 6 French guide. Require just a little, sometimes there is slight resistance, but they go. And let's see the same system here.
You have a 3 or 30 ready?
What now? This is the stent.
Yeah.
3.5.
3.5.
Yeah, no, but we'll just post dilate with the 3.5 also. Get a high pressure balloon.
So, Samin, now you're trying
Take the
to
other thing out.
prove that the 3.5 will
guideline
go
away.
through the.
Yep. Good.
So we took
Take
the
the
advantage
guideline,
of the guide liner.
Yeah.
So now you want to leave it there?
No guideline. We're deploying the stent. No, we
I
stand
understand,
in the
but
middle.
Then you
We're
pull
not
the
doing
guide
it.
back.
Yeah. No, we're just doing in the middle, right?
Yeah,
I
then,
mean, we're not contiguous. We just do a
Okay.
middle segment now.
then I pull the guide out, liner
Okay.
out. Yeah.
Ready?
Wait, let me get the guide liner out a little bit. Okay.
Take a picture.
No, some dye. So then we decide if you want me to pull the guide, stand back a little bit.
Your distal vessel looks beautiful in the
Okay,
meantime.
take a picture.
We need a 4th stent there. Huh?
Mm,
Okay, then just do it.
okay.
You don't want to overlap there?
Yeah, we need to go 1 millimeter in, and we need one more. 3.5. Good. Another 3.54. 24.
So now with 4 Endeavor stents, you think you can still have a shorter duration of antiplatelet therapy?
No, I would say continue Plavix lifelong on him.
Done.
One single butt. And although you're right, when we can give, because of this multiple stents, give it a challenge of aspirin, and now make sure that GI keep 1 extra day, that everything is fine. And so,
3.5, what you have? 24?
yeah.
Good.
Alexander, what's happening with structural heart disease in Brazil?
Oh, yeah, very, very active. We do have the core valve program with Medtronic going on. It's close to 60 patients in our center. We have a national registry of 200 patients, and Edwards is getting approved this month. So we really put together this valve team, which I think it's very, very helpful. And we are moving ahead now with a lot of devices being tested for neuroprotection and new femoral closure devices. So it's an exciting new field.
Yep. And everything is, all eyes are set for FDA tomorrow on the Edward, and lot of enthusiasm, nervousness, everything is there, because this will be a real set for the whole structural heart disease. But knowing that they already have the precedence of Melody valve for the pulmonic of Medtronic approved, so that they are very optimistic that once the trial has been so positive, that they will get a green light tomorrow. But I'm sure it will be a lots and lots of restriction that how it will be done. I think that's the whole thing. That is just like they regulated the carotid. I think that's what same thing going to happen for the TAVI. That how it will be regulated, that appropriate patients should go, and it is fully basically discussed and decided between the surgical, heart team, surgeons, interventionalists, and so on and so forth.
Anu, in the meantime, exactly the same technique with the guide liner
Yes,
and deploy.
what I did
Excellent,
was,
yeah.
wait, guide.
Floor on.
Now, so what exactly happened is, see that angle where I could not overlap the stent.
Right.
So just advance your guide liner first, and then the stent I was able to go. If you can see at that angle, when your second stent comes in, often you're not able to overlap it. And with the guide liner, I was able to do that.
Anu, how much overlapping are you doing these days?
One cell,
Okay.
a millimeter.
Mm-hmm.
Okay, ready? Go.
Now, if this looks good, then we just end. I know it has gone further. Actually, we also have 2 TAVI cases. They are getting ready other side. The 12 atmosphere and 14. And if need to be, go again and post dilate, but if requires. But once you are done, the debulking, as we said, that rotational atherectomy at our center around 10%, in the country wise about 1.8%. But clearly, that despite the rota, that how difficult this case has been is just an example that if you don't do a rota, that delivery of the stent, causing the guide dissection, and not a stent expansion could have been even further trouble. Let's come back to that.
In between.
Samin, you were mentioning about the busy week at FDA. I think they also have a ticagrelor coming up for approval this week.
Yep, that's right.
So not only is it going to be the federal deficit which the government has to tackle this week, they have to help with structural heart disease and pharmacology for interventional cardiology.
Yeah.
Hopefully that will be easier than the stimulus discussions.
Yeah, actually, you know what? It was so interesting. If you really go deep down to the ticagrelor data, and I know every time we just in the past we didn't pay much attention, but I've been a little involved in last few weeks on this issue. Actually, in North America, it was not that it was not beneficial. It was there was that odd ratio was against. Actually, the not benefit even towards the harm. They say, well, this is all related to aspirin dose, and patient received Plavix beforehand, but those are minor. But the key is, now you're ready to take a picture? Huh? Your wire has come back?
Yeah, I purposely did that.
So
All
this
right.
is
Take everything out. Good. With that note, maybe we just, what you say? Let's want to show the last picture?
No. We have to take a picture approximately.
Okay, good. Come back to the guide. Yeah.
Samin, in the meantime, take us through your take-home message for this case.
Yeah, exactly. Good. Ready?
Not yet.
Yeah,
There's
the
some
base.
nitro.
Yeah, let's take this picture first.
I want to pull back the guide a little.
Yeah, pull the guide a little bit, but clearly that this is the key. Yeah, good.
Looks beautiful.
Wow.
No post-expansion, nothing.
Not needed.
Absolutely right.
Not needed. And I just want to quickly just finish it. Basically, I think this was a very little different discussion today, but timely so. Because we have this ACC seminar, myself, Roxana and Maran and Laura Mori, and we actually had to close they put into a small room, 140 capacity, and there was no outside TVs, and they had to close the room so much because nothing is written on this field. So hopefully what we have shown today and published, this slide material will be useful for everybody. But I still think that duration for the antiplatelet therapy until showed is 12 months. Second issue, that if you require interruption, 7 days, keep it minimum. Kind of you can say 7 days is the sweetest part or honeymoon period. 7 days is good. After that is a problem. So they try to keep it 7 days, but at least go for 6 months if possible. And the lastly, that if we know that a patient has planned non-cardiac surgery, bare metal stent is appropriate in these cases, as long as it's not a very complex case. Like this case, we started with the bare metal, but you know that you put those 4 stents, restenosis rate will be close to 60-70% in this particular case. So that we change our approach, but use Endeavor, came out very good. And I really thank all my cath lab staff and of course.
Well, you need to also take your cath lab staff for 1 minute into your control room.
All right.
I think the other point about
Yes, Anu.
the technique here, remember the guide selection was there, and we were very much skeptical, did we need aggressive guide? If you see that, many times you would have seen the guide liner was almost in the mid to distal RCA, and even this guide came from the prox to the mid RCA, and if you see the final picture, how that 30% lesion looks like the way we started with. And this is another one I wanted to show you, another, see how it looks here. This is all wire bias. It's a nice demonstration of wire bias. So in this situation, what you do is to take your wire out, give some vasodilators, and then take your final picture, which looks here, this way.
And a very nicely done case, genuinely complex, lots of teaching tips, and you ready to celebrate your second anniversary?
All right. We really thank everyone, and I think they are a little case issues.
Yes, we need to move the camera onto the control room.
All right.
In the meantime, I want to let our viewers know session 26 is August 16.
I want to post the photo. Yeah, look at that.
We'll see you there. Hopefully, we'll continue to keep our tradition, which we have maintained over the last 2 years. Keep the cases complex. Keep giving you the teaching tips. Remain unbiased, maintain a scientific balance, and hopefully share with you the appropriateness criteria just about with every case. We don't see you there in the control room.
Right. Our cath lab staff can come here, everybody, guys and girls, on this side.
Now what we...
Okay.
This
Roxana
is to...
and, Alexander, the fellows. Come.
This is to
Everybody,
celebrate the second...
All right, our...
Pablo.
Roxana, nice seeing you there.
Where is Vicky? Is Vicky available? Get Vicky from other room.
Vicky and
Yeah.
yeah.
These are the main players.
Pablo is the main
Yeah.
main.
It is, you know, these are the unsung heroes who work almost as hard as all of us, and along with that is our remarkable camera crews which do a great job.
Who are the nurses in this room?
Christine.
Christine. Come here 1 minute. Everyone. Christine. Yeah, come here. Don't be afraid. Vicky, come.
Vicky.
Yeah, no, this is the live webcast birthday. 24th birthday.
God.
Yeah. All right.
And also, are we live now? Samir?
We are live, Anu.
Okay,
and
just to let you know, the control room of the cath lab that controls the entire Mount Sinai is this area. So everybody has to know, this is the control room.
We actually have our Shulanda could be on this side also. We actually have the operator in the cath lab here controlled, so that they actually 0935 is the Mount Sinai number, gets more phone calls than our main number exchange, which is 6500. All right. With that note, we really celebrate and thank everyone for our 2-year anniversary, and especially ice on the cake, Alexander being here. And thanks everyone, and I'll see all our viewers for next month, and next month again we'll show some special device.
Samin, thank you so much. We'll see you next time, August 16th. So sorry for the delay this time, but another exciting case.